Good evening and welcome back to Session 2 of the Immunisation Coalition's annual scientific meeting. In this session we have three speakers discussing issues around COVID-19 vaccination. The first talk of this session is should we vaccinate our children against COVID-19? The talk is presented by Dr. Shamez Ladani. Dr. Ladani is a paediatric infectious disease specialist at St George's University, London. He is a consulting epidemiologist at Public Health England, where he is clinical lead for a number of vaccine trials. Welcome, Shamez.
Thank you very much for giving me the opportunity to talk about COVID vaccines in children. This remains a highly controversial subject in many parts of the world because there are arguments both for and against vaccinating children against COVID. To make this talk interesting, what I have done is I've laid forward many arguments for vaccinating children, and at the same time I've provided some arguments against vaccinating children. And I hope that this will spark some debate that we can then use in the discussion afterwards as to what might be the best route forward in the current pandemic. So the arguments for vaccinating children are pretty strong. The first point is that children do get infected with the virus, just like adults do. The risk of infection in children is likely to be very similar to what we see in adults. And this is just one study on antibodies that we did in primary school children and staff at the beginning of the pandemic. And what you see is that there were antibody levels were very similar in the two groups, suggesting that children do get infected probably at the same level as the adults do. It's just that they are more likely to have asymptomatic or mild infections, which wouldn't get picked up by PCR testing unless we were doing it for asymptomatic infections too. And we have seen that over time with increased PCR testing, we are identifying many more children who otherwise would have missed if we are limiting the testing to symptomatic disease. Now, the consequence of that is that a small percentage of children will be hospitalized with COVID or need ICU, and some will die from COVID. These are potentially preventable through vaccination. We have done a number of studies trying to understand the risk of hospitalizations in children. This is just one study that was published recently and showed that several thousand children are admitted to the hospital every year, and a proportion of them will end up in ICU. We've also identified a proportion of children who will die of COVID, sadly. This proportion is actually very, very small. In the first year of the pandemic, there were only 61 deaths in children who had a positive virus, and of those, 25 were directly attributable to COVID. And within that group, 60% of them had life-limiting medical conditions. So it's rare, and it tends to affect those who have severe underlying comorbidities, and it's possible that vaccinating could help prevent severe complications of this virus. There are some children who develop persistent symptoms after COVID. It's known as post-acute COVID syndrome. It's also known as long COVID. We don't know as much about long COVID in children as we do in adults. This is a systematic review that we did recently, and it does suggest that the risk of persistent symptoms in children is likely to be very, very low. But there are some children who will develop long COVID symptoms who potentially may benefit from prevention through vaccination, but we still aren't able to define long COVID to be able to assess this risk and the benefits of vaccination in children, unlike adults where there are good data about long COVID and the benefits of vaccination to prevent long COVID. There is also the hyperinflammatory syndrome known as PIMS-TS in UK and MISC in the US. This is a rare but potentially fatal syndrome that occurs around 2 to 6 weeks after SARS-CoV infection. It's believed to be related to a hyperinflammatory immune response to the initial infection and can affect multiple organs with typical manifestations of Kawasaki disease and toxic shock syndrome in children. This can be rather severe. Many of the children end up in ICU, but fortunately the condition has a very low case fatality rate, and vast majority of them recover without any complications. But recent studies from the US do suggest that 2 doses of vaccine in teenagers could reduce the risk of PIMS-TS by up to 90%. On top of that, we know that children can transmit the virus to others, and especially because children have asymptomatic or mild infections, they may not get noticed as having an infection, and therefore they may be difficult to identify, test, and isolate to try and prevent further transmission. It's also very difficult to maintain physical distancing from young children, and therefore the best option might be to vaccinate them so that they are less likely to get COVID and potentially less likely to transmit the virus to others. With the current vaccines, the mRNA vaccines are the ones used in children. There is some evidence that they do protect against transmission. This is just one study that was published in Eurosurveillance recently with the Delta variant, showing that vaccinated adults were less likely to transmit the virus to others. The problem is that vaccination has very limited protection against infection and mild COVID, and the new variants seem to be able to evade immunity. And there are numerous reports of fully vaccinated adults still being able to transmit the virus to others. And it's likely that the same thing will happen with children who are vaccinated but still able to transmit the virus to others. We know that the vaccines are highly effective in preventing severe COVID in adolescents. There are now large-scale data from the US showing reductions in hospitalizations and critical care admissions in adolescents, with very high effectiveness in the period after 2 doses of COVID vaccines with mRNA vaccination. On top of that, the mRNA vaccines are reported to be safe in adolescents. There is a small risk of myocarditis after the second dose in young adults, but this risk appears to be very low, and the benefits of vaccination are considered to be much higher than the small risks of myocarditis. But at the same time, many of these arguments can be used against vaccinating children against COVID. For example, children may develop COVID, but we know that the risk of severe disease or death is extremely low. The vast majority of deaths occur in children with underlying comorbidities, and even they have a very low risk of severe COVID or a fatal outcome. Most children will develop a mild, transient, and self-limiting illness. And with regards to the rare hyperinflammatory syndromes, we now have very effective treatments for children, which when started early can prevent many of the complications that we were seeing early in the pandemic. This suggests that perhaps we can identify a specific group of children who might benefit from vaccination, such as those with comorbidities, who we know are disproportionately affected with severe COVID. There are concerns about myocarditis as well. They tend to occur generally after the second dose in young adult males and adolescent males as well. While the studies currently show that this is a mild, and while the current studies show that this is generally mild with only a few days of hospitalization with full recovery, there are concerns that we don't really know enough about myocarditis, which at the end of the day is inflammation of the heart muscle and its potential long-term outcomes, because there have been rare cases of scarring of the myocardium and pericardium, which will be lifelong. And so there is a jury out still that even though myocarditis it is rare, it could be severe and lifelong if it happens after vaccination. There's also increasing evidence that the current vaccines are providing only limited protection against symptomatic disease and transmission. And this is particularly the case with the new variants, and especially with the Omicron variant. This is the UK data looking at protection against symptomatic disease after 2 and 3 doses of an mRNA vaccine. And what you can see is that the vaccine effectiveness wanes very rapidly within a few weeks, reaching only 10% after 24 weeks. And after the booster, it's already fallen to nearly 50% by 10 weeks, which means that with a short period of time after your last dose of vaccine, you will still be susceptible to mild COVID. And it is also likely that you will be able to transmit even though you are fully vaccinated. Now, this is important for children because there is an argument that vaccinating children could be beneficial because they will stop spreading the virus to other children, especially in educational settings, and to their household members and potentially to their educational staff. But if these vaccines are not very effective at preventing mild COVID or transmission, then the argument for vaccinating children to protect others will not hold true, and that it would be much more efficient if we focused on vaccinating those who are most at risk and make sure that the adults are adequately protected um, so they do not develop severe COVID when they're exposed to the virus. Early data from the UK, this is after a single dose of vaccine in 12 to 15-year-olds and 16 to 17-year-olds, also show this waning of protection against symptomatic disease, and it's likely to be very similar to the adults, and this waning will happen even after the second dose of vaccine. There are also opportunity costs for vaccinating children against COVID, and when we spend all our time and resources in vaccinating teenagers, we are taking away that time and resources, especially healthcare staff, from other more critical work. For example, vaccinating teenagers means that there are less opportunities to vaccinate them against the routine teenage immunizations, which could have potential very long-term impact on individual and population immunity against many of the infectious diseases that remain well controlled. In the UK, we have the meningococcal ACWY vaccine for teenagers, which maintains herd immunity because of the high vaccine rates in teenagers. And this could potentially be disrupted if vaccine uptake falls in the teenagers in the coming months. For younger children, the 5 to 11-year-olds in primary schools, at the moment, we do not have a program for vaccination of this age group. So if we were to vaccinate them, we would have to establish a new program of vaccinating 5 to 11-year-olds, probably in school settings. And that would have to be set up from scratch, and the resources would have to come from other essential services that are being provided for children at the moment. There's also the argument that actually, like many other respiratory infections, the presence of transient infection in children does serve to maintain population immunity because it allows the virus to circulate and infect those who are fully vaccinated and build on immunity, getting a more hybrid immunity in those who are vaccinated, which will be sustained over a long period because the virus will circulate in the population. And finally, there's the argument that, by vaccinating teenagers who have a very low risk, we are taking vaccines away from many parts of the world where many adults, elderly people, and importantly to healthcare staff actually still do not have access to COVID vaccines. And perhaps we might be thinking more about equitable vaccination by allowing other countries to catch up with their primary immunizations in adults and high-risk groups before we vaccinate children. So just as a bit of summary and the caveats with what I've discussed is that I think it is clear, and I don't think there is any doubt that the benefits of vaccinating children are marginal. There are definitely pros to the vaccine, but they do come at a cost of risks, not only for COVID, but a general healthcare service provision in countries that are focusing on vaccinating children. And at the end of the day, the decision to vaccinate children is personal because it's a very fine balance between the very low risk of infection against the very low risk of vaccination. And often this is a personal choice that parents will make for their children. The discussions that I have undertaken in these arguments are based mainly around mRNA vaccines for adolescents. There is a lower dose of vaccine for 5 to 11-year-olds, and it is possible that these vaccines are safer in the younger age groups because of the lower risk, but they also have a lower risk of severe disease compared to the older children. And also, all the arguments I've given become even more complicated in younger children, such as the 2 to 4-year-olds and infants, because again, the risk benefits become even more marginal because of their very low risk of severe disease. Finally, the benefit risks are likely to be different for other vaccine platforms. mRNA vaccines are new. There are concerns about side effects such as myocarditis, which are relevant in a population with very low risk of severe disease. But there are other vaccines that may have better safety profiles and lower side effect profiles, such as conjugate vaccines, which may be a better option for children and teenagers, and potentially a live attenuated nasal vaccine, could be a solution for the younger children and could be given with nasal flu vaccine, for example, and that would become a very attractive option for the younger children. And with that, I thank you for your attention, and I look forward to the questions in the discussion.
Thanks, Shamez. Terrific presentation. Our next presentation is titled Boosters, a topic close to all of our hearts. It will be presented by Associate Professor Matthew Snape, who is in the Department of General Paediatrics and Vaccinology at the University of Oxford. He is also a Jenner investigator and a senior investigator and director of the National Immunisation Schedule Evaluation Consortium in the UK. Welcome, Matthew. We look forward to your talk.
Thanks very much, and thanks for the invitation to talk here. So I'm Matthew Snape, I'm a paediatrician, and I work at the Oxford Vaccine Group, and have been very involved in the mix and match studies that we've been doing here at the Oxford Vaccine Group. And these came about because of a call, actually, before we even... first in my disclosures, you can see them here. But these mix and match studies, which include the Cov Boost study, which has been led in Southampton, came about as part of the NICEP consortium. So I lead this consortium that have been doing a series of studies that are of use to UK immunisation policy, and it's very much come into its own during the COVID pandemic. During 2021, we have launched 6 clinical trials. We are enrolling over 5,500 participants that have directly informed UK and international policy on mixing schedules, concomitant influenza and COVID vaccination, we'll be hearing about from Rajeka, and choice of third dose vaccines, which is what I'll be focusing on today. So these came about initially because of a telephone conversation with Jonathan Van Tam, our Deputy Chief Medical Officer, who even before we had licensed vaccines saying we need to be thinking ahead. We're going to have multiple vaccines that are going to become available. All of these are going to be in 2-dose schedules, and there's going to be what happens if there is a supply problem or a safety signal with one of these vaccines. Are we going to be able to switch over to the other platform mid-schedule, if you like? So the question here was, could we be giving different vaccines for the primary immunisation schedule? Which rapidly evolved into, should we be doing this? Is this a better way to give vaccines? Could we be optimising the vaccine responses? And again, this is very relevant to looking at the third dose in the schedule, is can we optimise our immune responses by mixing and matching? Now, it's worth remembering this is really quite a novel approach to vaccine use. We're very used to schedules where you're giving the same vaccine at first, second, third dose. Or if there is a bit of a combination, it's often within the same platform or technology. So protein, you might use different manufacturers for a protein-based vaccine, for example. There's been some precedent with the viral vectored vaccines where there's been an awareness that giving the same viral vector repeatedly doesn't optimise the immune response. So the plan is to give different viral vectors, as is used with the Ebola vaccines made by Janssen, where you give Ad26 followed by MVA, or Sputnik V. But cross-platforms take this to the next step. And the challenges for these is there is no formal regulatory process. Manufacturers are generally reluctant because they're not going to be doing studies with other manufacturers' vaccines. And of course it can complicate a pharmacovigilance surveillance if you have a safety signal from one vaccine. And what we wouldn't want to be happening is to be locking people, delivery into an optimal mixed schedule, an optimal mixed schedule, which would be actually to likely delay rather than enhance deployment. We're focusing on enhancing flexibility and identifying any mixed schedules that should be avoided, and that's been the purpose of these studies, looking for any schedules with excessive reactogenicity or poor immunogenicity. So what have we learned? Firstly, we've learned that generating data on mixed schedules is important, as we know there was safety signal with the AstraZeneca vaccine, and very quickly the world actually had to switch to using, opted to switch to using mixed schedule, giving Ad26, the Oxford AstraZeneca vaccine followed by an RNA vaccine. And we studied this, and this was happening kind of in parallel, and we were able to show that actually all of the schedules that we studied generated a good immune response, at least as high as that of the 2 doses of the Oxford AstraZeneca vaccine. This is looking at binding antibodies on the left here, and the 2 doses of the Oxford AstraZeneca vaccine shown in yellow, and then the T-cell response is shown in the right. And we did this across this study, which is COMCOV, but also COMCOV2, which added in Mrna and Novavax into the mix. And very quickly, from these, we're able to generate some kind of key themes, if you like. What we're looking at here is a summary slide combining COMCOV2, which is at the left-hand column, and COMCOV, which is the right-hand column. Looking at antibodies in the top row and T-cells in the bottom row. and generated a crude rank order of the different schedules. And it's very apparent here that there is any schedule with an RNA vaccine it generated higher antibody levels. Moderna probably higher still than Pfizer. And then when you had Pfizer followed by Novavax, or the Oxford AstraZeneca followed by Novavax, it's somewhat in the mid-ranking. And then the threshold is set by 2 doses of Oxford AstraZeneca vaccine. So nothing magic about mixed schedules here in terms of the antibody response. If you have an RNA vaccine, you will have higher antibodies. Question is whether that you need more, whether more is always more, or whether it's a matter of enough is enough in terms of the antibodies. Interestingly, for the T cells, we saw a lot more variability, and a different theme came through, which is that the best T cell response comes if you give a viral vector prime, like Oxford AstraZeneca, and then a mixed boost. So either Novavax or Moderna or Pfizer, after the Oxford AstraZeneca, gave the highest T cell response. Whereas, intriguingly, giving the Pfizer followed by Novavax actually gave much lower T cell responses. So there's something very different in the way that viral vectors and RNA vaccines prime for a T cell response if you give a heterologous boost. And of course, that is also of relevance when it comes to thinking about what do we use for our booster doses. Other messages that we picked from these was there was no specific advantages for variants of concerns. If you had higher antibodies against the ancestral strain, you're going to have higher antibodies against the beta, and the drop-off was very consistent across the different platforms that we had. Nor was there any major difference in the rate of decline of antibodies or T cells after primary immunisation. So if you started with higher antibodies, you ended up with higher antibodies, and the rate of decline was very similar between them. We did see increased systemic reactions such as chills and malaise when you mixed viral vectored vaccines and an RNA vaccine. But this was not generally prohibitory and actually was minimised by increasing the interval between the two vaccines. So high when it was at 4-week interval, low when it was at a 12-week interval. Importantly, there were no major safety concerns. So this has ended up being incorporated into the interim recommendations for the heterologous COVID-19 vaccine schedules that came out of WHO at the end of last year. But then we think about, well, what about for the next vaccine, which is very much, of course, where the world is up to now. How does this relate to when we give a third dose of vaccination? So several studies have been looking at this. We have the study which has just been published in The Lancet by Sue-Ann Clemens, which is in Brazil. And this was looking at participants who've been primed with coronavac. So this is perhaps not so relevant to the Australian context, but globally this is very important. Lots of people who've received 2 doses of coronavac, the whole virus inactivated vaccine. And we know that the antibodies after that vaccine and effectiveness wanes relatively quickly. So here they took participants who received 2 doses of coronavac, came back to them 6 months later, and gave them either the Oxford AstraZeneca vaccine, another dose of the coronavac vaccine, the Janssen Ad26 vaccine, or the Pfizer vaccine down here. And you can see that actually, so in terms of persistence after the seropositivity 6 months after immunisation was very low, at most a quarter, down to around 4% in some contexts. This is in the over 61-year-olds, so very low in the over 61-year-olds. And then if you give another dose of coronavac, then your rise is really suboptimal. So that you only become seropositive in around 66% of participants here in this group here. And if you look at the top here, the geometric mean fold rise here was 12.4. Whereas if you give a viral vectored vaccine, such as the Oxford AstraZeneca vaccine or the Ad26, you're seeing around an 80 to 90-fold increase, and up to around 100, and it is 100% of participants becoming seropositive at that point. If you give a Pfizer vaccine, it's high still, 150-fold increase, and again, of course, 100% it's becoming seropositive. So this is important information, and that's against the ancestral strain, even more pronounced when it comes to Omicron, where you're actually seeing after the third dose, and the order has changed here, after the third dose of coronavac, only around 30% becoming seropositive, whereas in the other groups, after a booster dose of the Ad26 up to 99%, Pfizer 90 and Jad 90 here. So some real advantages to giving a different vaccine to the priming for those receiving coronavac. This is another study, just to mention, a very important study from the NIH, non-randomized study, where again they looked at the combinations they're using in America with Moderna, Pfizer or Ad26, and the main message that came out here was that if you'd been primed with Ad26, and this is looking at binding antibodies in the top row, if you were primed with Ad26 and you got a third dose of the Ad26 vaccine, not so much of an antibody increase as you had seen if you'd received an RNA vaccine, whether it be Pfizer or Moderna. So this brings us to the study that Sol Faust ran in Southampton called CovBoost, again part of this NICEC portfolio. And this was looking at many different options here. So these are the different vaccines that we were giving in this study. We took participants that had been primed with 2 doses of Pfizer or 2 doses of Oxford AstraZeneca and received their second dose at least 3 months previously, so 3-month interval between second and third dose. And we boosted them with either viral vectored vaccines, the one that you can see here. So the Oxford AstraZeneca vaccine is referred to as CHAD in these abbreviations, and then Ad26. Different RNA vaccines, so full dose Pfizer or a half dose Pfizer. Moderna, which is referred to as M1273, and of importance, this was given at a 100 microgram dose. As the study was enrolling, it became apparent that Moderna were going to be going for a 50 microgram dose for their third dose, whereas we were giving the full dose here, and that's being studied in a later study, 50 microgram. CureVac is a low-dose RNA vaccine, which has not progressed further. We looked at protein nanoparticle vaccines, Novavax or a half dose of Novavax, and an inactivated whole virus, Valneva. So that's the vaccines that we were given for a third dose. And this was a complicated study. This enrolled over 2,800 participants, half of whom received Oxford vaccine, half received Pfizer. And they were it was divided up into basically 3 sub-studies to be giving these different vaccines in different randomizations. And in each of these sub-studies, one group received MenACWY as a control vaccine, kind of as a comparator. So the ratios you'll be seeing are comparing a third dose of COVID vaccine compared to somebody who didn't get a COVID vaccine, got another vaccine instead. So in this group A, for example, done at a selection of sites, participants could receive either the Oxford AstraZeneca vaccine again, Novavax vaccine or half-dose Novavax or a control. Half of them have been primed with the Pfizer vaccines, half have been primed with Oxford AstraZeneca. Group B looked at different groups, vaccines, Group C at different vaccines. So in effect, actually, it was 6 sub-studies. This was enrolling people 10 to 12 weeks after their second jab, age range of 30 to 69-year-olds, and those over 70, so kind of stratification for that, with a good age spread, and did include people with mild to moderate comorbidities, but nobody with immunocompromise. So what did we learn from this? Now, we're running through a series of slides. The top row is always those that receive the 2 doses of the Oxford AstraZeneca vaccine as their priming vaccines, and the bottom row, those receive 2 doses of Pfizer. The first column is those who are under 70, second column is those that are over 70. And this is a radial graph looking at moderate to severe reactions. The middle line is 25%, the outer line is 50%. You can see the different reactions we're talking about here. We'll just highlight what we were looking for, which is what stands out. Was there anything that stood out as, above the other groups? So here we've got, for example, if you received 2 doses of Pfizer and were boosted with CHAD, the Oxford AstraZeneca vaccine, then you really were at higher rates of reactions, between 25 and 50% for many of these reactions, if you were under 70. Now these were transient. They weren't pleasant, but they passed. This is actually quite consistent with what we saw in the primary immunisation. This mix of RNA followed by viral vector or vice versa does tend to lead to increased reactions, but quite transient and not seen in the over 70-year-olds. This was looking at the ChAdOx and Novavax vaccines. This is now looking at Valneva and Pfizer, or half-dose Pfizer, or the Janssen vaccine, Ad26. Again, at the top, those primed with Oxford AstraZeneca, and some increase if you're boosted with Ad26 in either group. And especially, again, with Pfizer, followed by RNA, followed by Ad26, this viral vector combination does seem to bring out more in the under 70s, but not the over 70s. And finally, in Group C, probably the most reactogenic schedules included full-dose Moderna. And so here, primed with Oxford AstraZeneca, boosted with Moderna. Quite a lot of local pain there actually, and fatigue in both age groups. And even Pfizer followed by Moderna, seeing the same features there coming through, so a bit more reactogenic. So to summarise all of that, any grade local and systemic reactions were similar after all vaccines. That's looking at overall. And fatigue and headache were the most common systemic reactions, and pain the most frequent local reaction. Reactogenicity was greater in those under between 30 and 69 years compared to older participants. And those primed with Pfizer did receive more frequent local and systemic reactions after receiving a third dose of either Moderna at 100 micrograms or at CHAD and at 26. Now looking at the immunogenicity. And we're looking at the spike antibodies and the T cell response as measured by ELISpot at 28 days after the third dose. And this is a ratio comparing to the control group, not to baseline, but to the control group. So if you're to the left of this blue line, then that would favour the control, which of course would be unexpected, that you get higher antibody levels after a control vaccine than the COVID. If you're to the right, it's favouring the vaccine, and how far away gives you the idea of the height of the response, if you like, the fold rise. And this is looking at those now primed with Pfizer and giving a third dose of the vaccine, looking at geometric mean ratio. And here we see those primed with Pfizer, either primed with Pfizer, boosted with a half-dose Pfizer, so not that much difference between those two groups, although they weren't randomised directly together, they were in separate randomisations. And then Moderna generating the highest fold rise of all. We also gave Oxford AstraZeneca and AD26, saw a very impressive fold rise with those. Less impressive with giving Valneva or CureVac, and which is interesting. So the whole, after priming with RNA, very little rise, if any, after a whole viral boost. And here's the CureVac, less of a fold rise, and that's not been taken forward. For those primed with Oxford AstraZeneca now, similar themes coming through. Here is the RNA boost, so very impressive boosts that you see here, even with a half dose of Pfizer. A third dose of CHAD, so viral vectored here, does result in a threefold rise in antibodies, but it is starting from a lower baseline than what we saw with the Pfizer vaccine. So overall, these antibody levels are not as high after you receive Pfizer priming followed by CHAD or 3 doses of Pfizer. The AD26 boost tends to be a bit higher than after an Oxford AstraZeneca boost, around a 5 to 6-fold rise. And Novavax is up here, so again, an impressive rise with a third dose of Novavax. This schedule was very well tolerated. We didn't feature that earlier, but actually either of the Pfizer or Oxford AstraZeneca followed by Novavax was very well tolerated, and this does generate an impressive fold rise increase. Less so for Valneva, less so for CureVac. Now we're looking at the cellular immune response. This is actually more consistent across all of them, really just to bring out a few features that if you're primed with Pfizer and receiving either a Pfizer boost or a half Pfizer boost, you tend to see around antibody levels in the mid-range. Most impressive response was actually seen with Moderna here. And if you've been receiving the AZ priming, then very impressive responses with the Pfizer or Moderna when it comes to the T-cell responses. When it comes to the variants of concern, there was no specific advantage. What you can see here is on the x-axis, this is the wild type. On the y-axis, this is the Delta strain. What you see, and so if it was following a 45-degree angle, there would be no drop-off between them. What you see is a shift down, that parallel to the 45-degree line, and no differences between the groups. So actually, there is a drop-off, it's conserved, there's no magic difference with the different combination schedules. That was for antibodies. For T cells, we don't see much of a drop-off at all, much more of a conserved response, cellular immune response, as measured by T cell secreting, interferon gamma secreting T cells measured by ELISpot. So overall there, we can say that there is actually great flexibility for the use of mixed schedules. For the Pfizer primed, all but Valneva and CureVac generated a good humoral immune boost. For the AZ primed, the humoral boost was greatest with Pfizer, Moderna, AD26 or Novavax. Importantly, there's data from the UK Health Security Agency, what used to be Public Health England, showing this translate to real-world benefit. This is now looking at Delta versus Omicron. And here, the zero line is along here. So after 2 doses of AZ, up to 20 weeks, we're seeing no effectiveness against Omicron. But then after either a Pfizer or a Moderna boost, this effectiveness increases to around 60%. This is after 2 doses. If you're primed with 2 doses of Pfizer, again, dramatic drop in effectiveness of Omicron. This is against symptomatic infection. Great increase with either Pfizer or Moderna to over 60% up to near 80% initially. And with 2 doses of Moderna prime, again, with a Pfizer or Moderna boost, an increase in effectiveness against symptomatic infection. This is from the same data set, which is actually looking at a protection against symptomatic disease with those who have been primed with 2 doses of AZ, Pfizer or Moderna, and just contrasting that. So get this dropping off of effectiveness against Alpha or Delta now, but remembering that hospitalization is held much higher effectiveness here. The data for Omicron are coming through for this. So just to remind us, just to reinforce that although protection against symptomatic infection drops off, we do see higher protection against hospitalization, even against Omicron. Now, in the COV boost study, there's ongoing work being done by Sel Faust and his team, which is looking at analysing the antibodies at 3 months after immunisation to give an idea of how fast the peak antibody declines, and also looking at late boost arms to mirror the employment in the general population in the UK. And so they'll be getting people getting Pfizer, half-dose Pfizer, or half-dose Moderna. And indeed looking at 4th dose studies as well to see what happens in those, giving different options for the 4th dose to look ahead to possibly the next UK winter. So there's great flexibility in use of the mixed schedules. There is a transient increased reactogenicity with mixed adenoviral vectored and RNA vaccines and seen across 2nd and 3rd doses. All schedules with RNA generate the highest antibody titers. I think that's very evident now. But intriguingly, the T cells, the best signal is generated with either those with adenoviral priming, followed by heterologous boost. And inactivated whole virus vaccines actually generated a minimal boost after 2 doses of mRNA. Many people acknowledge this is just the Oxford people and others, but emphasising that Sel Faust has been really leading on the boost aspects of this and his team in Southampton. And this is delivered by an amazing network of sites across the UK that have been very supportive of these studies. So thank you, and very happy, looking forward to the discussion that will follow this talk. Thanks very much.
Thanks, Matthew, for a very informative talk. The third presentation is also highly practical. It's titled Co-Administration of COVID and Influenza Vaccination. The presentation is by Dr. Rajika Lazarus from the Bristol Trial Centre. Rajika has been working on a number of clinical vaccine trials since 2006. Over the last 18 months, she's been leading COVID-19 vaccine studies in the west of England. Welcome, Rajika.
Okay, thank you for that introduction and good evening, everyone. So this evening, I'm going to be talking primarily about a clinical trial that we delivered in the UK earlier last year. And we did that to inform the autumn vaccine policy. But before I talk about the results, I just have a few slides to put the work into context. So what I'm going to talk about is co-administration, concomitant administration. Now, this isn't a new thing. We do it all the time in children as part of the routine vaccination schedule. And as an adult, you may receive multiple vaccines if you're traveling or when it's indicated. If you do receive more than one vaccine, then you get one in each arm, or in the same arm, it needs to be separated by 2.5 centimetres. There are already some guidance on getting more than one vaccine at the same time. And you can see that for most vaccines, it's usually okay. If you have 2 or more inactivated vaccines, you can have them together or at any interval between the doses, although there are some exceptions. And these exceptions really relate to when you have the same antigen in the 2 different vaccines that then may compete and interfere with the immune response. So with the Tdap and the MenATWY, it's the toxoid, and obviously with the two pneumococcal vaccines, you've got an overlap in some of the pneumococcal serotypes contained. And then when we move on to live vaccines, it is recommended that you do leave a gap of 28 days between those two vaccines, and that's so there isn't an immune response interference unless they're administered together. The only exception to that is yellow fever and MMR. Okay, and looking at influenza vaccine, there are several studies that have been done already with the pneumococcal conjugate vaccine and the polysaccharide vaccine, with the standard flu vaccine plus the adjuvanted flu vaccine, and then again with the other vaccine that's often given in this age group, which is the herpes zoster vaccine. And these studies on the whole show that there are no safety signals when you give the vaccines together. The reactogenicity is similar when the vaccines are given alone or together, although there might be a slight increase when you give them together. And importantly, there's no significant impact on the immune response. So why was there the need to do the study looking at influenza and COVID-19 vaccines in such a hurry? And of course, when we started the study in the summer of 2021, the COVID-19 vaccines had only really been approved at the most for 6 months or so. So we were still really learning a lot about them. They were new, serious but very rare side effects being reported. So certainly the US said to avoid co-administration for abundance of caution. And in the UK, there was concern that any side effects that were detected would be incorrectly attributed. So it's really important to get that profile right and then go on to do the studies to work out what any potential side effects would look like. In addition to that, there were other factors that we needed to consider as well. So I've already talked about the immune interference and reactogenicity, so I'm just going to talk a little bit about the potential impact on uptake, delivery and timing. So theoretically, you may get better uptake if you give two vaccines at the same time, because the patient or individual only has to make one visit to the vaccine centre. Certainly in the UK, we see better uptake of the varicella zoster vaccine during the overlap with the influenza season, because people go and get their influenza vaccine and they get their VZ vaccine at the same time. But this isn't perfect, and certainly the uptake of the influenza vaccine is much higher than the pneumococcal vaccine. So we know that there are these missed opportunities. And some people may have a lack of confidence in having more than one vaccine together because concerned about having multiple antigens. And there are some studies looking at this in the adolescent setting, particularly around HPV, where it's shown that about in 50% of visits, HPV vaccine could have been given, and it wasn't given when children turned up for their flu vaccine. And some of the reasons for this were a lack of confidence. And then finally, we have the timing. I don't know what it was like when you were rolling out the COVID-19 vaccine, but queues like this were very typical. We set up large mass vaccination centres around the country where people would come and get their vaccines. And so with autumn approaching, if we had to give out both flu and COVID-19 vaccines, to have people queue like this twice over would have meant a kind of increased burden on our immunisation systems that are already fairly stretched. And the other thing that we were really concerned about at the time was the timing of the vaccine. If we gave the COVID-19 vaccine and then waited a while to give the flu vaccine, and not necessarily kind of waited because of a side effect reason or a immune response reason, but simply because we didn't have enough appointments to be able to give the COVID-19 vaccine 1 week and the flu vaccine next week, then we might not protect people in time for the flu season. And as you remember, the 2019-20 flu season was very quiet, with very low levels of influenza detected, and we were anticipating a potential resurgence in influenza But I've got to say, we've had very little influenza this year, so that hasn't happened. But still, kind of in the future, that timely vaccination to get people vaccinated in time for the winter respiratory virus season should be helped by concomitant vaccination. So what we did was a study that used both the kind of main approved COVID-19 vaccines in the UK. So that was the AZ vaccine that I referred to as ChAdOx, and the Pfizer vaccine, which I referred to as BNT, alongside the seasonal influenza vaccines, and what we were able to get it published in the Lancet towards the end of last year. And so what we really wanted to know was how reactogenic and how safe would it be to give both these vaccines at the same time. And so our measures were either local reactions or systemic reactions. We were giving one vaccine in each arm, so we were kind of less concerned about the local reactions and interference. So what we wanted to know really was about the impact of the systemic reactions when you had one vaccine or two vaccines, and overall safety. So what reactions were we interested in? So this is a graph taken from the original ChAdOx paper, and just highlighting the different types of systemic reactions. And where I've really circled is kind of there's an absence of fever with the second dose of the vaccine and very few severe reactions, but most people had at least one systemic event. So 65 in the younger cohort and 72% in the older cohort. And this is looking at the second dose of the BNT vaccine. And again, very similar rates of reactions, high rates, but again, very few severe adverse reactions there. So what we needed to do is to really come up with some pragmatic way of assessing reactogenicity. We wanted to include all the potential symptoms that I've listed there, so all the way through from fever to the flu-like symptoms and vomiting and diarrhea. And so to incorporate all of those, we decided to look at the number of participants reporting one or more of those systemic symptoms. And because the rate of severe reactions was very, very few, we decided to go for a non-inferiority margin of 25%. So we agreed that it would be clinically acceptable if there was an increase in 25% in the number of participants reporting one or more systemic reactions, given that these reactions were usually mild, moderate, and lasted for 1 or 2 days. In addition to that, we're also interested in immunogenicity, how acceptable it was to have two vaccines at the same time, and whether people lost days of work. And that was really important because at the time, particularly after the first dose of the AZ vaccine or after the second dose of the BNT vaccine, people often took a day or two off work because of side effects such as fever and chills. And this did have an impact as healthcare workers were the first to get the vaccines. So what we wanted to know was what was going to happen when people had their influenza dose with the presumed booster dose of the COVID-19 vaccines. We weren't entirely sure whether that was going to happen, but in the UK now we have rolled out third doses of the COVID-19 vaccine, and we have been using mRNA vaccines. So to try and get an idea what this would be like, we recruited individuals who were due to have their second dose of the COVID-19 vaccine in 2 age cohorts, those 65 and over and those under 65, and we separated them out into these 2 age cohorts because we have different influenza vaccines for these age cohorts recommended in the UK. So those who are 65 and over received a trivalent adjuvanted vaccine, and those who are under 65 received 1 or 2 quadrivalent vaccines. One was cellular based and one was a recombinant vaccine. So we ended up with these different study cohorts here, looking at the different combinations of vaccine. So you can see kind of the 6, so in each age group with each vaccine type. And what we did is that we invited people along, and if they were eligible to be in the study, and we had a very broad inclusion criteria. So we did include people with comorbidities and immunosuppression to really be pragmatic and include those people who would benefit from having both vaccines at the same time, and certainly those people who would be recommended to have flu vaccine routinely. So at the first visit, people were randomised to either get the COVID-19 vaccine alongside a placebo, which was a saline injection, or their age-appropriate influenza vaccine. We brought them back a month later, and those people who got the saline got a flu vaccine, and those people who got the flu vaccine got the saline. And we did this not really to look at a sequential vaccination schedule, but to kind of get a baseline for influenza vaccine alone for reactogenicity and immunogenicity. So moving on to the results. So the average age in our study for the young cohort was about just over 50, and the older cohort was about 69, mainly white British, and 85% of people had a previous influenza vaccine before, and about 30% of those were healthcare workers. So this was really the population who would have benefited from this study. So we were really pleased with that. And then in terms of our primary outcome, so this is looking at the reactogenicity. So to remind you, it's the percentage of participants with one or more systemic reactions. And what we did is that we looked at the difference between those who got the COVID-19 vaccine alone and those who got the COVID-19 vaccine alongside the flu. And you can see the dashed line that goes down the middle to 0. Along that line is a line of no difference. The red dashed line is our 25% non-inferiority margin. So anything that crosses that line, that means that it really isn't a significant difference in terms of the rate of reactions between the two groups. But you can see that for a couple of our groups, the 25% margin was just about exceeded. And that one of those groups was the ChAdOx group with the older adults with the adjuvanted flu vaccine. And in that group, there was just a slight exceedance of over 26%. And then another exceedance in the group where the younger adults who had the BNT vaccine, again, that was just by kind of a 0.25% difference there. And certainly in the younger cohort, we felt that we couldn't really comment on this too much because unfortunately we didn't recruit to that group fully related to the kind of rollout of the vaccine and trying to find the people who needed their second vaccine at the time we were doing the study. But certainly kind of in the older cohort, it does seem that there was an increased rate. However, this is relative, and even those people who had both vaccines together in the older cohort tended to get fewer reactions than those in the younger cohorts. And again, most of those reactions were mild and moderate reactions. When looking at the systemic and the local reactions here, so what you can see here are some graphs that show the COVID-19 vaccines with the flu next to the COVID-19 vaccine with the placebo. And you can see there isn't really too much difference between the two graphs there. And most of the local reactions were actually driven by the COVID-19 reaction. 83.5% of people reported at least one local reaction. There were 8 severe reactions, so grade 3 reactions reported in individuals, and that was all in the limb where people received the COVID-19 vaccine. And most of those were pain, and one was warmth. So 8 in total, 7 pain and 1 warmth. And then this is looking at the immunogenicity. So we did a very similar analysis. So looking at really the ratio of the response with the flu vaccine and without the flu vaccine. So the dashed line in the middle is 1, where there is no difference. So any of those results that cross that line essentially show there's no significant difference. And the blue dashed line there also kind of represents the kind of the ratio used by the WHO to assess for non-inferiority, and you can see that the lower confidence intervals are all well above that margin. So we can say that there really isn't a significant impact on the immunogenicity of the COVID-19 vaccines when they are given with the influenza vaccine. And then similarly with the flu vaccine, this is quite a busy slide, but we did test all 4 strains within the influenza vaccine. So you can see that we have the A strains there, and then at the top A and B, and then the B strains are C and D along the bottom there. And most of these lines, so the area to look at is day 21 post-influenza vaccine, which is at the bottom of each of those graphs there. And in most cases, then those results really do hover around the 1. But interestingly, we did find that with the recombinant quadrivalent flu vaccine and BNT, for 3 of the strains, there seemed to be an improved response to the COVID-19 vaccine. And the reasons for that are not clear, but that was in the group where we under-recruited. But it's an interesting signal to think about why that may have been the case. And onto our qualitative questions. So we asked people whether they would be happy to have 2 vaccines together again in the future. And only 9 of our 500 plus participants stated that they wouldn't be happy to have the concomitant vaccination in the future. And out of those 9, only 3 of them actually received the COVID-19 and flu vaccine together. And then in terms of missed work days, only 3.1% of those employed had time off work, and that due to vaccine-related adverse reactions. And out of that 11, only 7 of them had actually received the COVID-19 alongside the influenza vaccine. And so really, in summary, there were no safety concerns identified. There was no significant impact on the immunogenicity of the second dose of the COVID-19 vaccine, and the reactogenicity was very similar in most of the vaccine groups, but where there was an increase, this was thought to be acceptable as the reactions were mainly mild and moderate. And as well as the reactogenicity and immunogenicity, we need to think about kind of the broader point needed for implementation. So how's it gone in the UK with the results of this study? So I don't have the final data, but certainly I can say that not 100% of people got both vaccines together. And the main reasons for this were really about delivery. COVID-19 vaccines and influenza vaccines come from different supply routes in the UK. The people who deliver those vaccines are slightly different in terms of their location. So through the GPs or through our mass vaccination centres as well. And not all of them have the capacity to give both. So it's really good that we have this, but to make it work and get all the real efficiencies from this, kind of we need more thought into the kind of the broader practicalities. So got a lot of acknowledgements to make here. We did this study starting really in July and had the results ready to present in September. So there were a lot of people involved in making this happen. So thank you for your time, and I look forward to discussing this further.
Welcome, Shamez, Matthew and Rajika to the panel discussion. Thank you for terrific presentations. There were lots of questions. Shamez, there's a very direct one aimed at you, and it is, would you vaccinate your own healthy children at present? With the current...
It's a very personal question, and it is difficult. I have 2 daughters who are both eligible for the vaccine. And what happened with me is that they both got COVID during the summer before the vaccines were available to them. So I had a decision to make about whether I should vaccinate them after they got COVID. And at the moment, I'm in a good place because there is good evidence to suggest that 1 dose on top of infection does provide very good additional immunity, which is what they've had. They're not yet eligible for the second dose, and I'm not convinced how much additional benefit a second dose would have. So that's the situation with me.
Shamez, it was a second question about comparing the risks of COVID vaccination in children with other common childhood vaccines. And are you able to compare apples with apples, or are the risks of meningitis, measles, mumps, etc., different?
I think we're in a different place, and I don't think they're directly comparable. I think the vaccines, as they have gone through very rigorous assessments over time, and it's done and dusted. I think with COVID, it's very, very different. A lot of the comparisons, so one of the main things that you compare with is a value for money or cost effectiveness analysis. And I don't think that COVID vaccines necessarily go through that, because we have the vaccines and they're already pre-purchased for most countries and they're available. So, given that you have a free vaccine, you then end up in a situation where you're comparing the benefits versus the risk. And there are very few risks with the vaccine. It's a new vaccine. Some people are not sure whether the dosing is correct. Perhaps children, teenagers need lower doses of vaccines. But all in all, we do know that the vaccines do protect against that very small risk of severe disease in teenagers. And therefore, there is a benefit of giving the vaccines.
And there was a third question about what you're seeing in the long COVID clinics in children. Is it common or uncommon? How long does it last? What are the symptoms?
So long COVID is a whole talk on its own. It's very, very complicated because it's nothing like adults. And I think one of the problems, at least the UK has stuck with, is I think that the rates and the condition has been overinflated by surveys that probably didn't fare us well over time. So we're ending up with very large numbers of estimated cases. They say that 1 in 7 children, for example, have long COVID, which is not what we see in reality or in our clinics. But the definitions of any persistent symptoms for more than 4 weeks, for example, didn't help the cause. And you have children who have lost their taste or smell that are now classed in the same category as those who have chronic fatigue syndrome and maybe really unwell with the post-viral syndrome. And so the problem we are having at the moment is that to try and disentangle the real children with that very rare but severe persistent effects from the noise that is created by concerns of the parents and the media. And so I think we're not in a very good place with long COVID. All the good studies in children suggest that long COVID is extremely uncommon. We're talking less than 1%. But I don't think that we really have understood this, because it's probably a mixture of different syndromes. You do have the sensory ones where you have loss of smell and taste, and they're not the same as a chronic fatigues or a post-hospital severe ITU type of child. And we need to better define the conditions so we can target them to the right services. And I don't think we're there yet.
Thank you. There was a second question about long COVID aimed at all panel members, and that was the relationship between long COVID and previous vaccination status. Matthew, and then Rajika, would you comment on whether people who are vaccinated are more or less likely to develop long COVID?
I'm happy to go first on that, Rajika, if you want. But the obvious point is that if you're less likely to get infected, you're less likely to get post-COVID symptoms. That's an important starting point. And there are data coming out from Israel. It's just a preprint now that does suggest that your risk of, if you do then develop breakthrough infection, your risk of getting long COVID is about half of that, what it would have been, which is more or less in line with the data that came out from the UK in September. And obviously the Israel data is focused on RNA vaccines, whereas the UK is a mix. So it does suggest on both counts, it reduces your risk of long COVID.
I probably don't have anything more to add to that, really.
Yeah, it's a good reason for being vaccinated, I think. But
yeah. Matthew,
how that applies to the teenage population, which is an important question. I think that's really an important aspect. Those data are in older people rather than teenagers, so I don't think we specifically have the risk that aspect for teenagers. But as Shamez says, it's so hard to get a feel for and to disentangle the impacts of the lockdown on teenagers, which has just been so devastating for mental health here as well, and that so many teachers are stuck in their room regardless of whether they've had COVID or not. That's another aspect.
So just to add to that, Matthew is absolutely right. We don't have data for children. We don't have, including teenagers, and we know that their risk is already very, very low. Early indications suggest there's very little difference in symptom persistence in children who've had 1 dose compared to 0 doses, but we're very early in our analysis. But when you're dealing with such small numbers, to see an effect is going to be very, very difficult. And I do hope there are some good studies that support it, because I think long COVID is here to stay.
Yeah. Thank you. Matthew, as a prime mixer and matcher, have you got a favourite cocktail at the moment? And what outputs do you put most credence on? You know, the antibody response, the T cell response, the amount of side effects, and as a second question, do the side effects correlate to the immunogenicity?
Yep. Okay. So lots of things in that. At a group, and there's been some discussion in the chat about the side effects and reactogenicity. Firstly, absolutely really important that we will be looking at that at an individual level and how your reactions to first dose predict reactions to second dose. Just when we get our statisticians get time to really trawl through that properly. At a group level, they don't always correlate. Pfizer followed by Pfizer followed by Oxford AstraZeneca actually was quite reactogenic, but not as immunogenic as 2 doses of Pfizer, or Pfizer followed by Chad. So you can't assume Chad followed by Pfizer. So you can't assume that they're going that more reactions means better immune response. In terms of my favorite cocktail, many other answers come to mind, but in terms of vaccines, I actually do think that the Oxford AstraZeneca followed by Pfizer seems to have a fantastic combination of good antibodies and T cell responses. You do see much higher T cell responses with that than 2 doses of RNA. And the increased reactions that we saw are really offset if you spread that out to 12 weeks. Now I'm talking about primary immunization here, but that does seem to bring it out. I think it's clear you wouldn't want to keep giving repeated doses of the Oxford AZ vaccine, but you're not getting much of an increase in antibodies or T cells if that's all you're doing. So I think that's one to try and not do. That bringing in a mix does help there, bringing in RNA vaccine or indeed Novavax. For countries that don't have access to RNA vaccines, I think the Oxford AstraZeneca followed by Novavax is a combination that gives antibodies that are 4 times higher than just 2 doses of AZ and a T cell response that's the highest of any of them that we saw. So that combination, Oxford AstraZeneca followed by Novavax, actually seems to be really immunogenic and very well tolerated. There were no increased reactions compared to 2 doses of Oxford AstraZeneca for that combination. And that also applied at the 3rd dose. Again, really high T cells, good antibody levels. So that actually is one that does seem to work in particular very well, especially for countries without access to an RNA vaccine.
And antibodies versus T cells?
Yeah, the data we have so far does seem to show a good correlation between neutralizing antibodies and binding antibodies and symptomatic infection. You do see this differentiation between the different groups, and that potentially would give us some opportunity to try and say, okay, well, the people that are getting to this particular combination more likely to get just mild infection rather than progressing to severe. I have to say I've not seen anything that's come through in the data that gives a consistent signal to say that any one particularly strong T cell schedule is less likely to progress to severe disease than a straight RNA or straight viral vector. So nothing, because that would be where you might be able to differentiate the two to say, okay, well, the schedule doesn't give great antibodies, but gives fantastic T cells. People get sick, but don't get really sick. Haven't seen that yet, but I think that's that's something that needs to be looked into in more detail and may emerge.
Matthew, there was a specific question about a young adult who might have had a sort of an allergic, inverted commas, reaction to the 2nd dose of Pfizer. What would you recommend as a 3rd dose?
Yeah, and so they're coming up a problem against maybe you don't want to give Oxford AstraZeneca to a young adult. If they've truly had a truly anaphylactic reaction to Pfizer, you don't want to give an RNA vaccine. And then actually the Novavax vaccines would come in very well now. If that's, I know it's licensed in Australia. I don't know if it's available yet, but that actually would be a very reasonable combination because it does give a good antibody T cell, well tolerated, and is unlikely to trigger an anaphylactic reaction that was driving the Pfizer response.
Thank you. Rajika, the idea of giving vaccines together makes a lot of logistic sense. Are we sort of stimulating the immune system, flogging the immune system, or just unrelated? And does it matter on who you do it to in terms of do they have to be healthy, or if they're compromised, can you still do it?
Yeah, so I think in terms of the first question, we're continuously being bombarded by antigens all the time. So our immune system is very used to handling multiple antigens. So I do think kind of giving more than two vaccines or two vaccines at the same time is overloading the immune system. And your second question in terms about which groups. So I mean, that really depends on the type of vaccines. I mean, both of the vaccines that we're using for COVID and flu are inactivated, fortunately, which means they can be given to anyone, irrespective of any immune compromise they have. But I suppose the kind of second part of that is how do we optimize those vaccines to get the optimal response in people who might have immunocompromise.
In recruiting people, you were sort of recruiting from sort of the vaccine converted, I'm guessing, people who'd had vaccinations in the past. Did you, at the time of recruitment, was there any hesitancy about the idea of having two at once?
No, I think you're right. We were recruiting people who had already had a single dose of the vaccine, and then people who were prepared to come along and be part of the trial and have blood tests along with the vaccines. So there wasn't any hesitancy, but we did want to know how people felt about it, which is why we asked those qualitative questions as well, whether people would be prepared to have two vaccines in the future. And, fortunately, most people would be happy to.
A question for the whole panel, but there've been several comments about the decrease in influenza during the time of COVID, and whether it's directly related to lockdown and masks and an increased awareness of public health, or is there another biological reason? Any thoughts?
Chalmers, do you want to go on? Yeah.
Well, yes, so it's not just about influenza. We've seen a change in all respiratory viruses, and that would be more consistent with the physical distancing measures that we've had in place during the lockdown. And what is really interesting is that it's taking its time coming back, and it's not coming back like how we are expecting it to. So, for example, we haven't seen influenza come back at this part of the world, and we're quite surprised that even after opening lockdown, we haven't really seen much, even though it's early days. But then we had viruses such as the RSV virus that came in the summer and peaked and then didn't have a second season. So we've really messed up their ecology. And I think there is a lot to learn about how these viruses work as they come back into the population. And I think these are really exciting times to be working on respiratory viruses.
Matthew or Rajika?
I guess it was also... Go, Rajika, after you.
No, it's just about the lockdown measures. I mean, I think that there is certainly an element of the lockdown measures happening, and they are ongoing, even though kind of from September, before the Omicron wave, things were starting to be relaxed, but people were still working at home. And I think things like working at home are here to stay. I don't think we're ever going to go back to where we were. And in terms of wearing masks, a lot of people did continue to wear masks. And it's only actually a small period, a short period of time where mask wearing was not required in public places.
But Rajika, just out of curiosity, and you're right, children went back in the UK, they all went back to school full time with no mitigations in place. And we really didn't see these viruses coming back. And yet we've always assumed it's the children who are actually the hubs of infection, and we haven't seen that. And it just goes to show how little we know about the virus dynamics. And it'll be very interesting to see how that pans out in the next couple of years.
It's absolutely, and also I don't think you can take each country in isolation. You know, this is a hemisphere effect, isn't it? That so if there's, I mean, that's another thing to be thinking about, and perhaps look to see, did any countries have it, and was there any variation, or is it just that overall across the hemisphere there was less interactions and therefore less opportunities? Gives a way to understand, does influenza spread come from seeding in a country and then spread, or is it continual reintroductions, or exactly what phenomenon is going on here? Another aspect to it.
Even as we open up, does it tell us something about how we should behave when we're in close proximity to other people, with regard to masks and, you know, etiquette and so on?
Yeah. Well, is it a surprise that after the first SARS-CoV outbreak that face masks were more commonly used in countries that had experienced SARS, and that became actually not unusual? And is that where we're going here as well?
It is a very good question, because I think the risk perception of people has changed. I think they've realized that, you know, by having some mitigations, you can actually protect not just against this virus, but many viruses. And there is a possibility that there will be many who will feel that this is not an acceptable risk anymore, what we thought was normal. These are very challenging times, and I think people have already formed very strong opinions about how they want to go forward.
And what does it say for the tourism industry and international travel?
I think it's a lot of it is controlled by politics and government. So I think some countries have decided to take away all rules and regulations. The UK, I believe, is not asking for any testing to be done before or after, and are hoping to go back to normality, while others are going to be very strict and rigid about it. The idea that you need to be vaccinated is still being used by some countries, even though we know that it doesn't necessarily protect you against infection or transmission, but it does protect you against getting very sick. And so I think as vaccines become more and more available, you know, that will give more confidence for people to travel and for countries to allow them to travel. So we're still a long way away, because I think a lot of people are still scared of traveling.
Shimiz, thank you. Matthew, last word.
No, just last word was actually on the previous topic, which was about face masks and so on. I wonder if it's going to change behavior in healthcare, in hospitals, ongoing. You know, will it feel normal now to not be wearing a face mask? You know, if we have shown that you can reduce transmission in hospitals, and does that suddenly mean that we are actually, now the expectation has shifted, that on the wards, masks will become more normal or even necessary going forward? I wonder if that debate has shifted now.
I think that's a fabulous comment. And just as a personal one, I've been on COVID service for the last 3.5 weeks and examining, you know, 20 COVID positive patients' chests a day, and feel entirely safe. Well, as long as I've got an N90, a properly fitting N95 mask, you know. And so I don't go out in the public now without one, because of my experience at the hospital. And I absolutely agree, Matthew. I think if you want to protect yourself, you've got to protect what you breathe in, unless you know the air you're breathing is entirely safe.
I was thinking actually more sure yourself, but also transmission. Now, in terms of nosocomial infections, we all know this has been an issue for forever. And maybe we have now been forced into changing behavior that actually could make a bigger difference here going forward, just for routine viruses.
Yep, absolutely. Thank you. I think our time's up. So I'd like to thank our three panelists for terrific presentations, terrific discussions. So I'd also like to thank some sponsors: Sanofi, Seqirus, GSK, Pfizer, Moderna, MSD and AstraZeneca. And we've also been well supported by BioSelect, EBOS, Terry White, Chemmark and Team Medical Supplies.